Thank you, Axel. And I appreciate the opportunity, and I apologize that you'll see me up here a few times. But I'll also note that I'm here for the updates, not for the debates, which probably is a testimony to my lack of persuasion, perhaps. But despite that, I'm going to try to persuade you about the relevance here of B-RAF V600E mutation. And what I want to do is really convince you of two things. One is that this is a very aggressive subtype of colorectal cancer. And the second is that we actually have therapies that have now moved into clinical practice, and we have opportunities to continue to enroll patients in clinical trials and improve outcomes. So this is the 50,000-foot view, but what I'll be focusing on is really the B-RAF mutated subgroup here. So the first point is to reiterate that when we're talking about B-RAF, what we're in this context, what we're talking about is the most common mutation, which is the V600E mutation. This is an activating mutation, same one that's in melanoma, some lung cancers, some thyroid cancers. This is a mutation that makes the enzyme constitutively active. Now, as an aside, and I'll touch on this a little later, time pending, that there are other B-RAF mutations that are of mixed activity, and some of them are inactivating. And these actually, as Axel has shown, this actually is a group that has better prognosis. So when we talk about B-RAF, one of the key things is actually to remember that we're talking about the most common V600E mutation. So when you get that report that comes back on the patient, that's the one to flag. Now, this is also behaves very differently. And you know, for those that are testing and identify these B-RAF mutations in their patients, they know that these are patients that have poor survival. This is the 80405 data, which recapitulates a number of studies that have shown the same thing. But this is in the presence of a B-RAF mutation, median survival is 12.9 months versus 34 months for B-RAF wild type. Now, there is some heterogeneity in that, but I think the majority of patients, what we see is this aggressive and poor survival. Now, this is also associated with a very atypical pattern of spread, right? This is not the common oligometastatic disease to the liver. We'll hear more about that from Kathy Yang and Mike Chodia in the discussion about what does all this mean and how do we integrate it with hepatectomy. But this is a population that has a high prevalence of spread to the peritoneum, to distant lymph nodes, and even, although it's still not common, even to the CNS. So this is, I think, one of the key messages is that because of its poor prognosis, that it's very different behavior and different biology as well, that this is a tumor that we need to really treat differently. We need to think about this as a different track of treatment than our standard metastatic colorectal cancers. So one of the things you'll see in the guidelines for B-RAF mutated V600E tumors is this idea that this is an aggressive tumor and we need aggressive chemotherapy. And so I show some of the data from FOLFOXIRI-BEV, so the triplet cytotoxics with bevacizumab. And what you can see in this complex curve here is that there are two green curves at the bottom that are both the B-RAF mutated patient population, and you can see the difference with FOLFOXIRI when at the start versus FOLFIRI. And while this is not significant in this analysis, it has been something that I think the practice pattern in patients who can tolerate it has been moving towards, because we do see that this is able to control the tumor out of the gate in many settings. So what about inhibition of the B-RAF protein? Well, a long body of work by many investigators has identified that when you inhibit B-RAF, that the tumor adapts. And this adapts through a number of different mechanisms, but the most prominent of that is that when you inhibit B-RAF, you unleash a feedback mechanism. And this feedback mechanism results in activation of EGFR. So this is a key distinction, because when we think about EGFR inhibitors and B-RAF mutated tumors, we know that they're not that sensitive. We don't see responses like we do in RAS wild-type tumors. But this is a tumor that's not dramatically driven by EGFR innately. But it's only when you inhibit B-RAF and you get this feedback activation of EGFR that now you uncover this dependency to EGFR. Okay, so EGFR alone, not very useful. B-RAF alone, not very useful. But the combination, as you can see in this PDX experiment here, where you can see the curves for these are really overlapping, and it's only when you combine the two that you block that first B-RAF and block that feedback mechanism. So with David Hong at our institution, we did a phase 1B with vemurafenib and cetuximab and irinotecan, and we're able to show that indeed you can now start to induce responses in this. And this is what we call the VIC regimen, or vemurafenib, irinotecan, and cetuximab. But there's been a number of these studies that have looked at both the singlets, which have very minimal activity, doublets, or even triplets. And I'll show you some of this data. But I think what we see is response rates continue to climb as you are including the EGFR inhibition, and the duration of progression-free survival improves as well. So the only randomized study to date in this space has been the SWOG 1406 study. This was a study, again, of BRAF V600E, so not the other atypical BRAF. And this is in second or third line metastatic colorectal cancer. Patients were randomized to cetuximab and irinotecan with or without vemurafenib. Endpoint was progression-free survival with an optional crossover. This study has been reported out last year and was a positive study with a hazard ratio of 0.48. And you can see that it extended the median progression-free survival, albeit from 4 to 4.3. And we'll come back to that point. But it does improve the progression-free survival in this setting. When we look at response rates and disease control rates, we see that the triplet was superior to the doublet. And I show you the waterfall plots here on the right for the two different arms that showing that while there is in this case, 2 patients that had a response on the doublet, that the disease control was substantially higher with the triplet. When patients who have been treated with an EGFR inhibitor and then progress, cross over, they do get benefit. And I think that's an important point, because sometimes we don't recognize that they have a BRAF mutation until after they've received an EGFR inhibitor, if you're testing BRAF late or getting a patient referred in. And what we see is that the combination still provides substantial benefit for patients, even if they've had a prior EGFR inhibitor. And so, again, it's this idea of the synergistic interaction of those two agents. Adverse events, the vemurafenib does add to the neutropenia, the nausea, and the anemia. There is no substantial difference with the rate of fatigue, trend towards worsening in diarrhea as well. So like any of these, learning how to manage vemurafenib is important. And so this is a regimen that has been added to the NCCN guidelines as a level 2A, and vemurafenib is now in the compendium for this indication. And I just show the regimen there. So again, the VIC regimen is now considered part of standard of care per NCCN for second line and beyond. And again, BRAF V600E only. And that's especially critical for vemurafenib, because it's actually designed to be specific for the V600E, the V600E structure. So it's not a very good pan-RAF inhibitor or inhibiting wild-type RAF or other BRAF mutations. And so this is very specific for the V600E. Well, how can we do better? So one of the things that, that has been identified is that when the patients progress, and I showed you that that can happen after several months of therapy, there is a clear mechanism whereby MAP kinase pathway, right, the same pathway of the RAS and the BRAF and the MEK, the MAP kinase pathway gets reactivated. So this is a tumor that is absolutely addicted to the MAP kinase pathway. This is not finding other pathways to activate, to bypass. It's finding ways to reactivate that exact same pathway. And I just show a highlight here of different mechanisms, RAS mutations, you get EGFR, KRAS amplifications, MEK mutations, and then there's a number of other mutations that have been identified. And intriguingly, even when we thought the tumor may be actually identifying an alternate pathway, like a acquired P10 mutation, it turned out that that was actually altering binding and signaling through RAS signaling, through MAP kinase. So every signal that we've seen in these patients, looking at how the tumor adapts, suggests this is a MAP kinase pathway dependent tumor. So just to show you one of the stories here, and we can really characterize this in mouse models, where we can do the vemurafenib alone and have no benefit. The combination can control the tumor for an extended period of time before we get an outgrowth of the tumor. And when we see that, we'll see these acquired mutation. And so what we're seeing in many cases is the acquisition of RAS mutations. And here's just a laundry list of the number of different mechanisms that we've identified in the lab that corresponds with what we're seeing in patients. And I think this is important because classically, obviously, we think about KRAS and NRAS as being mutually, KRAS and B-RAF as being mutually exclusive. Right? We don't usually see those in an untreated patient, but what happens at the time of resistance is that we've shown that there are indeed rare clones that have a KRAS or an NRAS mutation in a tumor of B-RAF V600 colon cancer. And those rare clones then can outgrow, and they're there for the sole reason of reactivating the MAP kinase pathway. So some work done by talented junior faculty Van Morris in my lab has demonstrated that when you actually take a model and now you maximize the MAP kinase inhibition, right? If they're really addicted to the MAP kinase pathway, then what we need to do is go back in and really try to shut that down. Now, we know that MEK inhibitors is one such mechanism to do it. We have limitations as patients of how much MEK inhibitor we can take because we start to have problems with vision, toxicity, and a rash can creep up. It turns out that mice can tolerate a much higher level of a MEK inhibitor. So we actually can do the experiments where we do a super physiologic dose of MEK, not to say that this is the combination that could be useful in patients by itself, but to show if we really go back and shut that down, what happens. And this is just to convince you this point that when you do this, what you can do is you can take a resistant tumor, even one that has a KRAS mutation. Here's two models with KRAS mutations. You can then induce regressions again. So reiterating that this is MAP kinase addicted. But how can we do this clinically? Well, one approach is to really look at the triplet. And as I alluded to earlier, when we do the triplet of a B-RAF, MEK, and EGFR to head off that resistance and try to maximize the inhibition of the pathway, what we can see, as is shown here on the right, is the BEACON study. So binimetinib, encorafenib, cetuximab. We did a 30-patient run-in that looked at a single-arm run-in with that triplet for BRAF V600E patients. What we saw was a 48% response rate, and impressively, the progression-free survival that now is double what we're seeing from the earlier regimens. So now progression-free survival out at 8 months. So this is an ongoing phase 3 study. It's the Beacon study, a large international effort, and it's randomizing patients to the control arm of FOLFIRI cetuximab or irinotecan cetuximab in second or third line settings. So this is identical design to the prior SWOG 1406 study. There's two experimental arms. The primary endpoint is the triplet binimetinib, encorafenib, cetuximab, but also encorafenib, cetuximab arm as well. So if you have a patient that has not received prior EGFR inhibitor, this is I think a very attractive study, and really this represents some of the best activity that we're seeing currently with these agents. So there's been interest in other approaches. So, okay, you told me that it's all MAP kinase driven. Well, what if we just keep pounding on the MAP kinase pathway? And we'll remember from our cancer biology training that the next enzyme down from the MEK is ERK, and there have been ERK inhibitors that are in clinical development, although one was recently discontinued last week, but nevertheless, there's still interest and agents coming. This is a cancer research publication that demonstrated that in vitro, when you generate these resistant mutations, that the triplet, that's the D and T and C arm here, can provide some benefit, as can the ERK inhibitor alone or in combination in some but not all settings. And so there's been some interest in really thinking about this. There was a nice cancer discovery paper from the group of Ryan Corcoran that was published last month that looked at the combination of B-RAF EGFR and B-RAF ERK EGFR, and the question here was not how to reverse resistance, but can the triplet with the ERK delay the onset of MAP kinase reactivation? And this is a model that rapidly developed resistance, but when you had the ERK inhibitor, you could get regression, but more importantly, prevent outgrowth. And when one looks at these clones, so here are the number of clones that he mixed together, the group mixed together, I should say, into this model, what you can see is that at the end of the experiment, when you have these rare clones that are present at the beginning, and you give just a B-RAF and an EGFR, that you can see an outgrowth of those resistant clones, meaning that this was not able to suppress these alternate pathways. But at least at the duration at the end of the study, when you use the B-RAF ERK EGFR, you're still able to continue to suppress those clones. They're there. They haven't gone away, but the ability to control it is there. So I mentioned this is to say where is this inhibition of B-RAF in signaling going in the future, and there's been some interest in ERK. I'm not sure it's going to be the panacea that's going to address every resistance mechanism, but the hope is that this could potentially provide a better approach. And again, it reiterates, as all these studies are, that this is such a MAP kinase dependent tumor. So the final point to make is that B-RAF does not live in isolation. The B-RAF mutation occurs in a very specific molecular context, and I think that's important, that there is a substantial epigenetic component of dysregulation, and this is a tumor type that has a very interesting biologic overlay with a microsatellite instability. We know that B-RAF does have a higher than expected number of MSI high tumors, but even in the microsatellite stable B-RAF, what we see is that these are tumors that are behaving in many ways in an immune microenvironment way, like an MSI high. And so another way to look at that is to actually look at an MSI high like gene signature and a B-RAF-like signature, and you can see that these are really very similar features. The other approach here is just looking at even within microsatellite stable V600E or the wild types, there's a difference. So this has raised some interest in the role of immunotherapy, and this is especially critical because we know the MAP kinase pathway has clear modes of immune suppression in cancer, and I won't go through all of these, but just know that this is a substantial area of interest, and this idea that can we target the tumor with the MAP kinase, also targeting the tumor microenvironment at the same time, and then take advantage of some of the synergy we're seeing between MEK and PD-1, for example. And you will see one or two of these studies being activated, hopefully here in the next 6 months, starting to look at how do you combine optimal MAP kinase inhibition in the BRAF context of microsatellite patients with PD-1 inhibition. So I'll end there and thank some of the lab members whose data I shared, and thank you for your time.